So the next speaker is Dr. Nimita Vijayan. Okay. You are presenting OCT biomarkers for good visual outcomes after cataract surgery in presence of epiretinal membrane.
Yes.
You
Yes.
can proceed with your
Coming to
presentation.
introduction, the idiopathic epiretinal membrane is a proliferation of glial tissue on the surface of the macula. Its incidence of 5.4 is present. Prevalence ranges from 4 to 8.5%. 90% of patients remain asymptomatic. The epiretinal membrane and cataract commonly occurs together, and detection and grading and assessment for visual outcomes is necessary for treating the mode of surgery that is needed. The need of the R to establish markers to identify the preoperative characteristics that may be a predictive value and would justify the necessity of a combined surgery need to be addressed. Briefly, the pathogenesis. The five types of cells involved are the RP, the fibrocytes, the fibrous astrocytes, the macrophages, and theories. The microglial cells migrate the segments of the cellular which remain on the retinal surface, thereby creating avulsion defects. In the era of OCT, we have differentiated the ERM based on four grades: in the presence of a foveal pit and the definition of the retinal fiber layers. And coming to the study, there are various lacunates in the other studies. They have all studied the magnitude of the visual acuity and the incidence of CME, the progression of ERM following cataract surgery. Neither the history of the ERM after cataract surgery nor the prognostic factors were implicated. So, in the present scenario, it is important for us to decide the mode of surgery that is required for a patient. Are we over-diagnosing these cases? Are we over-treating these patients? All these need to be addressed. And hence, coming to my study, which aims at analyzing the post-operative visual outcomes after cataract surgery in the presence of an idiopathic epiretinal membrane, and to analyze the predictive factors for a good visual outcome. The materials and methods, it is a retrospective study in the Department of Vitreoretinal Sciences, Chaitanya Eye Hospital, for a period of 6 months. 37 eyes of 37 patients were included. The inclusion criteria being eyes diagnosed with cataract and idiopathic epiretinal membrane. Exclusion criteria combined surgery patients, secondary ERMs, PCR patients, coexisting retinal pathologies. The data and parameters, all the preoperative parameters were included, and the SD-OCT using the spectralis machine was done. Post-operatively, after 6 weeks, the vision was taken and categorized into two groups. Group 1 included poor visual acuity group, that is without two-line improvement, and Group 2 included a good visual acuity group with two-line improvement. And the OCT parameters analyzed were the foveal contour pit, the central foveal thickness, intraretinal irregularities, ELM, EZ disruption, ERM staging, taut hyaloid, posterior hyaloid, and subretinal fluid. Coming on to the results, 13 patients were included in the Group 1, that is a poor visual acuity group, 24 patients in Group 2, that is a good visual acuity group, and the mean age was 71.08. The preoperative CFT was comparable in both the groups. The statistically non-significant parameters included the grade of cataract, the ERM grading, the subretinal fluid, foveal contour, the intraretinal irregularities, the ELM, EZ disruption, taut posterior hyaloid, and the ILM dehiscence and drill were all statistically significant parameters. Coming on to the discussion, the stage of ERM. 61.5% patients in the poor visual acuity group had type 1 ERM. So this implicated that the staging of ERM had nothing to do with the visual outcome. Jose et al. In his study had also, in accordance with our study, reported the similar findings. However, the presence of an ectopic inner foveal layer, as evidenced by Govito et al., showed that there was a lower visual acuity in such patients. The intraretinal irregularities was present in 84.6% patients, and they had poor visual outcomes. And this was evidenced again by Kwan et al., who also had a similar finding, and they had stated that it is a better marker than the CFT interdigitation zone for prognosticating visual outcomes. The ELM EZ disruption was present in 76% patients, and all of these belong to the poor visual acuity group, as evidenced by Tiago et al., Jose et al. In their previous studies. The interesting part, the good visual acuity group patients had no taut posterior hyaloid, and hence taut posterior hyaloid is an indicator of anatomic and functional ERM progression, as evidenced by K. Bed et al. The ELM dehiscence was present in 55% patients with poor visual acuity, and also evidenced by Lee et al. In their study. What they had seen was 53.5% patients with ILM dehiscence. There was a delay in the post-operative restoration of the inner retinal layers, so implicating low visual acuity. The drill was another significant biomarker, and 68% patients had poor visual acuity who had drill in them, and drill grading function was an important factor for the functional and anatomical measure for predicting the visual outcome. Now coming on to the other parameters, the CFT, the foveal contour, and the subretinal fluid, all of these were little significant parameters. The other biomarkers which had a numerical value but did not show statistical significance was the presence of subretinal deposits which had a lesser visual acuity, presence of sukema, there was improved visual acuity, and the prose length longer the better. Coming on to the conclusion, the positive biomarkers included the intact IRL, the intact ELM, attached vitreoretinal interface, absence of HRF, the negative biomarkers, intraretinal irregularities, ELM, the taut posterior hyaloid drill, the ILM dehiscence, limitations of a study, lack of data regarding pre-op metamorphopsia, small study, non-randomized study, retrospective short follow-up period, take-home message. And this is what we currently use in our clinical setup. The following biomarkers were associated with poor visual acuity after cataract surgery. The ELM, EZ disruption, drill, the presence of intraretinal cysts, schisis, hyperreflective foci, all of this implicated the presence would indicate the need of a combined surgery, that is a cataract plus a vitrectomy. However, the following features associated with good visual acuity, that is the intact IRL, the ELM, EZ, attached VR interface, absence of HRF, implicated that the patient just requires a standalone cataract surgery, and the pre-op foveal contour and CFT was controversial, and the BCVA and inner retinal deformation was reversible. The BCA with outer retinal damage was irreversible. The prognostic factors of EIRM following cataract surgery may help in a better counseling of patients and a better surgical outcome. Thank you.
Your success parameters was improvement from presenting vision, is that right? But that will be a little bit vague, no? Suppose the patient comes with a near mature cataract with very poor visibility, and you're able to pick up on the OCT. You'll have a considerable visual improvement. So the amount of vision improvement will be more dependent on the severity of the cataract and how low or how good the presenting vision is. Suppose the patient comes with 6/9 vision, he may not have even much of a scope ceiling effect will be there. So ideally, should have taken a final post-operative visual acuity and tried to correlate that with whatever parameters you have put up.
That was taken. So post-operative visual acuity was a standard of our thing.
But when you said good vision and poor vision in the initial slide, it seemed...
post-operative finding.
No. How did you classify as good vision and poor vision? Good outcome and poor outcome?
Good vision is patients with two-line improvement, and poor vision.
That's what I'm saying. That's what I'm saying. So you're saying improvement from presentation, no?
Okay.
So that will give a wrong idea of what is to be expected. You would have to go on with the final visual acuity post-op, and then correlated near 6/9 and better will be good vision, or 6/12 and below would have been something like that. You make a division and then try to correlate, rather than trying to look at the improvement from, because in our population, people tend to come late for surgery sometimes. So they'll come with poor visual acuity, but the doubling will be very high because the presenting vision is poor mainly because of cataract. So it will totally confound your results. That's what I thought.
Even I had the same feeling. We could have taken actually pseudophakic when the study was OCT biomarkers and ERM. Cataract would have been a big confounding factor. It would have been better if you had selected pseudophakic eyes.
You could have gone with the final visual acuity rather than the improvement from baseline.
And taut posterior hyaloid, is it a confounding factor as far as final visual acuity is?
Yes, it was a good. It was a negative biomarker.
And was it associated with EZ loss or any other change, or independently a taut
Independently,
posterior hyaloid?
it was an independent finding.
One of your conclusion was that with drill you will go for a combined surgery.
Yes.
Is
No.
that correct? Yeah.
Drill combined surgery. Yes.
Combined.
It's a negative biomarker.
So rather than doing cataract, she wants to combine both. The things are okay, but only thing your initial parameter which you took for success was not very robust. That's what I thought.
Thank you, sir.